Good afternoon, everyone. Yes, you're in the right place. We will be with you in about 5 minutes. We're just allowing people who had difficulty logging in to log on. So stay there and we'll be right back to you. Thank you. Good afternoon, everyone. I'm Gráinne Healy, Chair of the Sláintecare Citizen Staff Engagement Forum, and I'm delighted to welcome you to today's webinar, the third Sláintecare Integration Fund webinar, part of our Learning Network event series. We will be live with you for about an hour and a quarter today, bringing you the good practices from health and care right across the sector. We are taking questions during the broadcast, and we'll be making the questions and answers available to you after the webinar. So if you're asking a question or making a comment, please do indicate who the question is for, and we'll make sure to get the answers to you during the webinar or post them up afterwards. So please use the chat box, which is the feature on the top right-hand side of your screen. We're very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is, as you know, about providing right care in the right place at the right time by the right team. And in these webinars, you'll hear how the project funded by the Sláintecare Integration Fund and some HSE funded work is showing us best practice for healthcare reform and showing how they've adapted work practices and created improved pathways while responding to COVID-19. This afternoon, our focus is on how services are working differently to improve the experiences for people living with chronic diseases. We've asked 3 projects to share their learnings from COVID-19 and to tell us how their new work practices have changed. And we will investigate the sustainability into the future of these changes. We're going to also hear from some senior health professionals to get an overview on their experiences of integrated care improvements, dealing with chronic conditions, which reflect Sláintecare objectives of right care, right place, right time. We'll be bringing you more new practices in forthcoming webinars, and some of the suggestions you've made in your feedback will feature. Our next, for example, on the 10th of September, will feature how e-health initiatives are supporting the delivery of Sláintecare, leading to improved care pathways and better health outcomes. We're now going to hear from Dr. Ronan Fawcett. I spoke to Ronan earlier this week, and he told me about some of the crucial developments he has seen in approaches to chronic disease management. We're then going to hear from Dr. Siobhan Nivreen. Siobhan is a consultant old age psychiatrist with Tala Hospital, and she's also the HSE Integrated Care Lead with a special interest in integrated care pathways. Siobhan is going to tell us about the importance of integrated pathways for chronic disease management, but let's hear first from Ronan Fawcett.
So I'm really delighted to have Dr. Ronan Fawcett with us to have a conversation. Ronan is known to many people. He's a full-time GP, chair of the Carla Kilkenny ICGP St. Luke's Hospital Integrated Care Committee, and he's also a member of the Sláintecare Implementation Advisory Council. You're very welcome, Ronan. Thanks very much for your time today. So Ronan, what we were going to do is really talk to you in relation to chronic disease management. What are some of the changes in work practices that you've seen, maybe particularly during COVID-19, that you'd like to see continue to deliver Sláintecare's right care, right place, right time? And maybe you talk about that in the first instance, some of the practices that you like.
Yeah, Gráinne, I've been a doctor now for 40 years. I've seen more changes in the last 5 months than I have seen in my whole career. It's quite extraordinary how much integration has actually happened in the last few months. It's almost like Sláintecare has been put on steroids. It's great to see a lot of the changes. But there are 5 basic things that I've seen in my practice and over the last while which made a difference. The use of technology. This is now the new norm, I think, for healthcare delivery. Telemedicine is here to stay, and it is best medicine in the COVID age because it's safe for everybody. E-prescribing, e-certification, e-referrals, the new norm They are breathtakingly different, and they have made a huge difference to how we can provide care in an integrated way. The virtual clinics have taken off, and you will be talking to Ken MacDonald and what he's done later on, and it's good to see that. But we've become the Zoom generation, and we see this not only in information but in education and sharing messages. And it's great to see it because the bigger agents, the colleges have taken it on. It's a great way to communicate. But the fundamental principle of all this technological change is the principle that we move the data, not the patient, that we actually allow the data to travel, but not the patient. And you will see that in some of the projects that you'll be talking about later on. And I think this concept is gaining in confidence and in currency. We are seeing now more patient to GP consultations on the phone. We're seeing more GP consultant virtual clinics, and there's more diagnostics being done online, plus consultations now between consultants and patients. So we're in the age of technology. That's the first thing, and we need to grab it and make it safer. The second thing, and I've seen, is we now are in an era of self-care. And I see it in all my consultations with patients that I'm looking for their temperature, I'm looking for their blood pressure, and they now expect to have a blood pressure gadget at home. They now expect to have a temperature thermometer, and we're getting them to measure pulse and weight in kilos, please. So self-care is here, and we need to encourage it, because we can manage acute care, and we can also manage chronic disease much better if we can share the data over the phone or whatever. The third thing I've seen in my own practice is the flexible kind of remodeling of the GP-led team in the practice. Because of the circumstances, a lot of our staff had to train up to do other roles, like checking temperatures coming in, like doing ECGs, like doing phlebotomy, and that frees up the nurse time and the doctor time to actually concentrate on chronic disease or even the acute care. So that reframing of the practice. And the other thing in the practice that I've seen is the focusing on the priority patients. This kind of mental risk stratification of who are my high-risk patients, who are my cancer patients, who need the extra phone call, who needs to come in, and you focus on the at-risk group. And it's almost like a semi-structured care for people with dementia, people even in nursing homes, mental health. So we've been able to restructure our care. And the last thing I've seen in the culture change is citizens and communities are now energized and mobilized in ways I have not seen before, even locally, down to visiting at-risk people at home, dropping bloods to the hospital for us. Like, there's an energy and an enthusiasm we need to capture in the citizens to move forward with chronic disease management, because chronic disease management doesn't rely on the doctor. It's actually 4 levels of care. You have self-care, where people look after themselves. The next step up is informal care, where communities help each other informally, NGOs, etc. Then you have primary care, and then you have secondary care. But they need to be linked, and they need to be maximized. And that's what's begun to happen during COVID. And that's why I'm very exercised by what's happening, particularly with the technology.
Yeah, great. A really clear outline of the changes, which, as you said, I mean, these are changes people have been talking about doing for years.
Yeah.
Some people have been doing them in small spots, but the extent of the change, as you say, has been incredible over 5 or 6 months. So, given that people have now started on these practices, whether it's, you know, GPs or consultants, or I love your description of the citizens and communities getting energized and getting involved, what do you think we need to sustain and maximize these into the future?
That's a really key question, because we're really talking about cultural change here, and you really have to nourish the roots, the green shoots that are emerging. First thing, the government needs to continue, I think, to support the practice supports that they put in to support telemedicine in the community. That needs to continue for the time being. But we need to put telemedicine on a solid basis, and that means we need this individual health identifier needs to be nailed, done, delivered, done. We need to be able to transfer information seamlessly between primary, secondary care, an electronic health record, summary care record, so that we can safely share the data rather than the patient actually traveling. And that means putting technology on a very solid base. So that's the second thing. The third thing, I think Sláintecare has a great opportunity to develop an e-platform for healthcare, an e-portal, bit like what they did in New Zealand with their health pathways, where GPs can actively access this for local information, local guidance, consultant advice, or clinic times, and refer to hospital in a timely way. And this Sláintecare platform could also allow patients and the community to engage and find out what's available locally. Where is my Alzheimer's Day Centre? Who can I talk to about my mental health? So you're actually enabling self-care, and you're enabling informal care, and you're actually helping primary and secondary care to go together. And I think that would be a key step forward for us if we could develop that platform. And that will get real care in real time to the right person in the right place. I think we need to scale. The fourth thing I think we need to do is to scale those things that are working, like the virtual clinics, those technology-assisted platforms that we've done. The day of pilotitis is over. Post-COVID, there'll be no looking back. We need to keep going. We need to work with what works and scale it. So virtual clinics need to be extended, and I've been very privileged to work with the Heart Failure Virtual Clinic over the last 6 years, and I would love to see that grow and become mainstream, and that to be available for every GP and every patient, every family in Ireland. There's no reason why it can't. I think the fifth thing we need to do is we need to actively and more actively promote self-care, and we need to get consistent messaging from the health service executive to them through the media about what that means and what you can do for yourself. A bit like COVID, we had ads day and night telling us what to do, what not to do. We need to get onto the page to mobilize the citizens, mobilize the voluntarism that's out there, and it's innate. And then finally, the sixth thing I see, and I'm putting on my GP hat, is that I think we need to support the GP practices to develop the team that's needed in the community to manage the community. And that means, and let's be frank about it, we need more GPs. And the magic number, according to Frank Murray's manpower report last week, is 5,000, not 3 as we currently have. We need to double our practice nurses. We need clinical pharmacists. We need social prescribers. We need practice assistants. We need to build an effective, efficient team going forward. And we need new discussions about how that is empowered through the clinic with the networks, the new networks. Maybe it will need contractual change, but we need real energy to develop the practice-led team so we can actually deliver population health in a proper way.
So that's really about building the infrastructure that we have seen emerge in a sort of an ad hoc manner in the last 6 months, and making that mainstream, every practice having that infrastructure.
Yes, so that you now harmonise care nationally, the same way the hospitals have tried to do, and I've been involved in hospital groups. They tried to standardise and harmonise care among hospitals, which is the right thing. It was done with the cancer programme. And people are alive today, wouldn't have been alive today because services were standardised and harmonised and integrated. And we need to do the same within primary care, within general practice. And I think there's a real opportunity there.
And Ronan, just maybe to finish off, I mean, just talk a little bit about the importance of, you know, properly managing chronic disease.
God, yeah. Now, doing that in 2 minutes is going to be tricky, but I'll try. Chronic disease matters. It is absolutely the Achilles heel of the health service, because it's the frail little old lady who ends up in the ED and ends up spending 9 days in the hospital, who comes out worse than she went in. And we need to keep focused. We have 1 million people in Ireland with the 3 or 4 biggies: the diabetes, COPD, diabetes, asthma. 1 million, that's a fifth of the population have these chronic disease. They account for 40% of hospital admissions, 55% of the hospital costs, and that's enormous. 75% of the hospital beds, and we don't have enough beds, and our population is getting older. But from a GP point of view, they're 80% of our work. They're 80% of our consults. So this is a huge issue, and it's not going to go away. So using technology well is hugely important to how we move the care into the community in an agreed, managed way. And I think virtual clinics is one way of doing it. E-discharges. There's so much we can do in technology around chronic disease. But I also think this new GP contractual change that happens in January, where GPs now are looking after the over 70s in a structured program for those diseases, is very good, and it needs to be supported. And practices need to be supported to get their nurse numbers up, to get their space, because space in practices is the biggest problem. But 80% of the chronic disease Grania, can be managed by the GP and the GP team. The GP by the team. Must remember this. 15% will be shared between the hospital and the GP, and 5% is bad enough to warrant hospital only. And those numbers are universal. So we have to be engaged both in the community to build a team, and also at the interface with the hospital, so that we have better pathways in and out of hospital, and that we can actually manage that better. So we need new GP contractual change around developing this chronic disease, so that we go down the years very quickly, and there is a plan to do that. So the last thing I would say about chronic disease and what we need to do is we need to build a team to provide the right care, right place, right time. That's what Sláintecare is about. Move to a culture of proactive care, and you can't do that if you've only half a nurse in your practice. You can't do it if you don't have a practice assistant. So we need to build proactive care through population health management. That's the key. So we do need the more GPs, we need the practice nurses, but we also need to build the business links with hospitals so that the interface is maximized. So the access to consultant advice rather than hospitals is done, rather than sending people for consultant advice into an ED, where actually you meet a junior doctor, you are not getting the opinion of a senior doctor, and you're just adding to the problem of messed up care. So we need to put a lot of energy into maximizing hospitals, and we need to find methods to doing that. So I would say that COVID has accelerated the vision and mission and activity of Sláintecare. COVID has actually allowed us to accelerate what we're doing, and people are no longer confused about why we need a functioning health system. COVID worked really well. GPs, hospitals, the government, the HSE worked together with one vision to look after this population with COVID through a difficult time. Money was not an object. Technology was not an object. There was no barrier put anywhere. A single health system dealing with a single problem. We need to have the same energy, passion, determination when it comes to chronic disease management, because as I said at the start, that's the Achilles heel of the health system.
Dr. Ronan Fawcett, thank you very much.
Thank you.
So I'm really delighted to have.
So Siobhan Ivrin, you're so welcome. Thank you very much for joining us this afternoon. Many of you will know Siobhan as a consultant old age psychiatrist with Tala University Hospital, but she is also the HSE integrated care lead. And this afternoon, because we're focusing on chronic disease management, we're delighted that Siobhan has joined with us. Siobhan, I suppose we're wondering about chronic disease management. What are the kinds of work practices and maybe changes in work practices that you've seen develop during COVID-19 that you would welcome, and why?
So Grania, from the very start of the COVID pandemic, we were very aware of the need to provide care for people outside of the hospital setting as well as inside of the hospital setting. And as you know, we were all looking at those terrible scenes in Italy and indeed in Spain, where people weren't able to get into hospital, or perhaps weren't getting as much care as they could have got, and we were very lucky to have learned from that. So one of the things we stood up very early on were the COVID response teams. And the COVID response teams were set up by the CHOs to garner their expertise and experience of some of our specialists in the hospital setting. So that included our geriatricians, including our community geriatricians, infection prevention and control, and palliative care. And those specialists were able to provide care and advice and support to people in residential care settings, be those nursing homes or other types of residential care settings, including disability settings. Now, a lot of that expertise was supported by public health, who would have identified areas that were in crisis and help those areas to help those residential care settings to manage their patients. But what we really learned from that was the delivery of that specialist care in the local setting was very important from the patient point of view and the staff point of view. And it meant that people didn't have to be unnecessarily transferred to the hospital setting, that they were looked after by staff who were upskilled in their work, and that there was expertise available to the longer term or residential care setting when it was needed. So our big learning, I guess, was that there was the provision of expertise outside of the hospital setting, and how important that was from both the patient and staff point of view.
And Siobhan, did that mean that you were focusing a lot on using technologies? What way were you managing to change? So I know, for example, the idea of right care as close to home as possible, that you were managing to see a lot of that. Did technology play some role in that?
Well, initially with our COVID response team, a lot of it was by phone when it had to be. However, Infection Prevention and Control led a series of webinars led by Professor Martin McCormick, and, for example, on how to manage IPC in the long-term care setting, also how to don and doff PPE. And I can tell you that we had often upwards of 1,000 people on those webinars, which Professor McCormick is still running 4 different settings. So that was a really good use, I think, of virtual or telehealth techniques. We're still in the early stages of developing other platforms for outpatients or for other forms of healthcare delivery. But again, we've moved on from that, from where we were delivering it by phone initially, Grania. We've got a number of platforms now, including one called Attend Anywhere, which is widely used in the NHS, other telehealth platforms called Blue Eye that enable virtual consultations. Right. Some of those have happened in the longer term care setting, but also a lot of them happened in the hospital setting and in our community specialist settings like mental health.
Mm-hmm. And I know that you've seen a huge increase in those numbers, and that you're very pleased with that. Just talk a little bit maybe about the numbers, what you were looking at maybe a few months ago, and then the numbers that you've seen using those types of platforms.
So early on in March, there were approximately 35,000 consultations in the acute setting, using mostly telephone and then other more sophisticated means. Again, our mental health services reoriented themselves very rapidly and they were using the phone. But up to date, we've had over 280,000 consultations, virtual consultations, just in the acute sector. And again, a considerable number in the community sector. And that's been using those multiple means of communication that I've been describing, not just telephone, but video consultation as well.
And the learning from that in terms of why people are so keen, I suppose in the first instance, patients are going for this. You've seen I believe, a reduction in no-shows.
Huge reduction in no-shows. It's down to less than 1% in the acute sector at this point in time, and again we know it's much lower in the mental health sector as well. With many of my colleagues saying we have virtually no do not attends, as I say, down to less than 1%. Average DNA rates will be in the region of 10 to 15% and often higher. So you can see a massive reduction. We can only guess at the reasons for that at the moment, but we do think that people much prefer to be looked after on the doorstep. They don't have to make those bus journeys, maybe look for parking, whatever the difficulties are that make it for people to go to their community setting or their acute hospital setting. People do seem to respond very well to this virtual approach. And
that's over 280,000 fewer visits, footfall on campuses of hospitals in acute. So all of the benefits of that as well, I think, are superb. So in terms of some of these changes in practices, Siobhan, what do you think is needed to sustain these changes that you've seen? What needs to be put in place or I suppose maximised to keep these changes?
Well, the other change that I didn't mention, Grania, but I'd like to mention because it's very much part of this, we've always worked closely with our GP colleagues, but that relationship has improved greatly, and we've worked much more closely with them now over the last number of months. So any development we've had has been in conjunction with our GP colleagues supporting and advising. So for example, myself or Colin Henry would do regular telecoms with the GPs and get their feedback, their advice on what's working or what's not working. So enabling our GPs to have contact with specialist services through virtual means as well is something we're working very closely on. The other One of the other things I personally am very keen to see work done on is the development of the healthcare pathways, like the Canterbury pathways. And I think that would be a very big enabler.
Just
of how
explain that to people if they don't know about it.
So they are the development of pathways that are suitable for local or regional areas that if, for example, somebody presents with a headache or depression or whatever, there is a local pathway that a GP can tap into. They'll have an algorithm for care and a referral pathway when needs be. And that can be made very suitable for the local area, depending on whether you have a level 2 or level 3 hospital, what the mental health service is, what the primary care service is. So I've talked to a number of colleagues about that, and we would be very keen to see an improvement both in our infrastructural capacity from an IT point of view, but also in the development of things like the Canterbury Health Pathways in Ireland to facilitate virtual pathways of care.
Very good. So again, we're seeing the benefits of that in terms of, for patients, local care, not having to move out of your local area, not having to travel, and at the same time then for both the GPs and the consultants being able to give the right care to people when they need it by the right team.
Absolutely, absolutely.
Great stuff. Siobhan, thank you so much for your expertise and all the great work that you're doing, and thank you for your time. We really appreciate it this afternoon. Thank you very much.
You're very welcome, Grania. Listen, thank you very much and good luck with the webinar. Thank you.
Thank you. Thank you very much.
Thank you to both Ronan Fawcett and Siobhan Nivreen for sharing their views of the new integrated care pathways and some of the COVID-19 influenced work caring for those with chronic diseases and improving both the experiences of patients and indeed improving health and care outcomes. Ronan's message of moving data, not the patient, is an interesting one, and it features in the first project we're showcasing today. Indeed, each of today's Integrated Fund projects show the importance of improving patient experience for those with chronic health conditions. First up, we're now going to hear from Ireland East Hospital Group, who've set up a project with an innovative approach to heart failure treatment, which facilitates real-time online specialist support to GPs and provides prompt access to diagnostics in a community setting. Let's hear now from Professor Ken MacDonald, who's the founder and medical director of the Heart Failure Unit at St Vincent's University Hospital in Dublin.
Good afternoon, everyone. I'm delighted to be able to bring you all up to date on our Sláintecare project, looking at the importance of virtual consultation and integrated nurse, especially nurse delivery of heart failure services in the community. As we all know, this is fundamental to our efforts to change the method and nature of outpatient care delivery as we presently know it. Simply one background slide. We're all aware at present that our outpatient system is basically an attempt to provide care through a one system or one size fits all approach. And this has certainly been shown over the last several years to be ineffective, with climbing waiting times and frustration at the level of the patient and the general practitioner and the specialist and everyone involved. And driven by the apparent failure of this system, but also by many other changes which are outlined in the slide above at the top, including demographic changes, an older, frailer population with more chronic illness, an economic need to try and move away from hospital-dominated care, which is a major driver, of course. But on the positive side, a capacity now, an emerging capacity to provide care by different modalities, leveraging information technology and communication developments. And then interestingly, as this was developing, but not driven by the COVID-19 pandemic, the pandemic certainly underlined the need for us to develop an alternative platform for outpatient service delivery. At the bottom of the slide, I've simply a reminder there for those of us in cardiology, but it's pertinent to those of us in any specialty in healthcare delivery, including general practice and allied healthcare, that as we change the platform of outpatient care delivery, we need to also educate ourselves on how this new platform works, because it's not simply like turning a page in a book. The virtual consultation service is schematically presented here on a slide, and it simply, in short, provides real-time online case discussion between the general practitioner and the specialist team to do exactly what you would do in the face-to-face clinic. But the advantages are multiple. You can see in inverted commas, or deal with, if you want to use that phrase, more patients per hour of time. You also end up with less being referred to the standard face-to-face clinic. You can have a CME quality to this type of interaction, with GPs often joining in even though they don't have a case to present. And even with the case being presented to the GP will learn skills through the simple interaction with the specialist that he or she will be able to bring to subsequent cases and reduce subsequent referral. And importantly also, there's a benefit to the patient, even though the patient is not directly involved with this, is that the patient can in many cases be saved unnecessary travel. And that is more and more complicated for, as I highlighted in the first slide, an older, frailer population. The nuts and bolts of the clinic are really important, because you can say something is good, but when you get down to the detail, it often poses challenges. I'm not going to read through every aspect of setup that I've listed here in the setup and the running of the clinic, but importantly, from the point of view of this particular project, we wanted, under the setup of a case there highlighted in red, we wanted to know from the general practitioner, if they didn't have this VC virtual consultation service, what would they have used instead, because that would show the impact of the virtual consultation. And then in the running of the clinic, it's very important. Multiple aspects are important, but I think important to highlight that electronic reports are generated back to the GP surgery within 24 hours of finishing the clinic, which is a remarkable advance in and of itself compared to the present communication modalities we use with a general practitioner, which is simply by letter usually. And also important to highlight that the discussion is taped, so we can always go back over any decision that we've made and just ensure that we're all on the same page. So with this background, we started the virtual consultation concept back in January 2015. Started interestingly from an idea from one of my general practitioner colleagues down in Wexford, and it was a fantastic light bulb moment, if you want to call it that. And we started together and moseyed along at quite a slow pace initially in 2015, just to try and get a feel for this type of interaction. But then from late 2015 up to 2016, we began to expand it, as you can see in the graph there, with red being the number of GPs involved, and red being the number of cases, and the blue being the number of GPs involved. You can see that in that major operational year between the end of 2015 and the end of 2016, 140 cases were done. With this information and the benefit of it, we were able to persuade the HSC to fund the Carl Kilkenny project from 2016, not indeed to fund the original site, which was the East Coast Vincent's catchment, but to fund an alternate site in Carl Kilkenny. This slide now shows on the left the Carl Kilkenny experience when it started in December 2016 up until December 19, showing cases that were discussed. And you can see a very impressive uptake in terms of number of cases over this period. And again, in total in that region, 124 GPs engaged with the project, which shows a very keen interest in it. And then on the right, you simply see the East Coast, which was the origin of the birthplace of the VC project, combined with the Kilkenny experience, showing in total over 1,000 cases and over 200 GPs involved. The Carl Kilkenny experience was enhanced by having clinical nurse specialists in the community who provided an important critical link between general practice and general and specialist services in evolving and putting into play decisions that were made at the virtual consultation service. In my view, this particular aspect of the service is critical to leveraging its capacity to the maximum. This then brought us to the Sláintecare project, the evolution of the Carl Kilkenny project experience and also the East Coast experience. And the Sláintecare project was to expand it out to the north side of Dublin, to the Mater region. And this simply shows the major target of the project, which is obviously still running. It's been funded between January and December this year. And you can see that we have, instead of achieving our target of about 100 cases by May of 2020, we've achieved, in fact, over twice that number, reflecting the fact that the uptake and enthusiasm for this, despite the fact that it was launched during the COVID pandemic, was very significant, and there was great enthusiasm to engage with this particular format of outpatient care delivery. This particular slide is I think particularly important, is that it shows how the experience gained from initial centres can be leveraged to ensure that when you spread the service, the uptake is in fact quicker than it was originally. And what this slide shows over a 3-month period outlined on the horizontal axis, the number of patients initially in the first 3 months in this St. Vincent's catchment area back in 2016, a similar number in the first 3 months in the Carlow-Kilkenny catchment area in 2017, and then the number of patients in the first 2 months, we only had 2 months when we were making this slide, in the Mater area, and you can see that the uptake in the Mater area, because of the experience gleaned in the Vincent's catchment and Carlow-Kilkenny, which enhanced the uptake in the Mater area, was far more dramatic. So what do the users think of this? Most importantly here, first off, is the general practitioner view. On the left, showing results of a questionnaire referring to different aspects of heart failure care scored from 0 to 4 in terms of whether or not a benefit to major benefit. And you can see no matter what the question that the GP was asked to answer, whether it was knowledge about heart failure, access to expertise and competence, you can see that there was a strong support of the value of this service. The GP testimonials you can see on the right, and again, I won't read them, but you can see they are overwhelmingly positive for this service. Moving on to the patient's view of this, and again, you might say, well, how does the patient have a view since they're not involved? Well, obviously the GP is talking to the patient saying we're getting this consultation by a slightly different method than standard. And when it was explained to the patient and when the feedback was explained to the patient, and in particular when the clinical nurse specialist involved in this project talked to the patient and said, we've got the view of the specialist, patient and their family, you can see the testimonials there, again, overwhelmingly positive for this service. Down on the bottom left, you can see an estimate of the miles or kilometers saved by not requiring patients to travel. However, this slide is the most important because this shows the clinical impact of the service. And what this is refers back to, you remember in the slide showing the setup of the service, one of the questions we asked the GP is, what would you have done if you didn't have the virtual consultation? And without the virtual consultation, for every 100 cases, 78% would have gone to the outpatient department, 12 to the AMU or ED, and 10 to community, would be an ongoing community care. As a result of the virtual consultation, the 78 being referred to and added to this growing face-to-face outpatient waiting list, 78% became 8%, 12% going to the acute services became 2%, and there was a complete inversion of community care from 10% to a 90% shared general practitioner specialist care within the community. And you can see on the right, the KPIs for the project have been achieved to date and will of course be achieved by the end of the year given the strong success of this to date. This has also empowered us, I think, to be able to consider how to expand the use of the virtual consultation concept within cardiology. We're moving away solely from heart failure into general cardiology. And this has been particularly important in the COVID period where GPs want to get advice on patient care without sending patients into risky zones such as hospital. We've also recently expanded the use of VC care to bring specialist care to the nursing home, again, to try and obviate the need for nursing home patients to be transferred into hospital. And we're using VC now increasingly to bring a patient education format to the patient and their family at home, and also to try and update care plans in stable patients without, again, them needing to come to see us in a hospital setting. So in summary, that's the update of the project. It's been, in our view and the view of all involved with it, patients, general practitioners and the specialist teams, a resounding success to date, and I think it will help transform fundamentally the way we deliver outpatient care. Thank you.
That's great. Thank you very much, Ken. I'll come back to you with some questions in our panel session later on, but I think it's very clear from what you've presented that you're really getting superb uptake and very encouraging engagement with the virtual consultation service. We're now going to hear from Dr. Ronan Canavan, and Ronan is a consultant endocrinologist with St. Vincent's University Hospital. Also Anita Murray, senior podiatrist with St. Columbkille's and St. Vincent's University Hospital and CHO6, and Carmel Devine, podiatry manager from CHO3. We will hear how two projects working collaboratively have adapted to the COVID-19 crisis to respond to the needs of patients in the integrated foot protection services in CHO3 and CHO6. And we're mindful of the inclusion of the patient voice today, and we will hear in this snip from the patient experience from Pat and Paul.
So we all know that when a patient presents with a heart attack or presents with cancer, the health service steps up and puts them onto emergency care. The same outcomes, the same processes and approaches are needed with the diabetic foot. A patient who undergoes an amputation is really in the same category of risk of mortality and death in the next 5 years as a patient with a highly active cancer. A patient with a heart attack needs to get rapid treatment when they present. A patient with a diabetic foot, if they don't get the right treatment in the right way within the first day or two, the foot can rapidly progress and you can lead to loss of limb. So we've been fortunate with the project from Sláintecare to get the bolts of it set up and about to get up and running, and we felt we had good pathways for rapid access when the patient was deteriorating, appropriate timing, moving the patients out into the community closer to their local areas and care delivered locally. And then COVID hit us out of the blue. I think our initial thoughts in terms of, well, COVID was an emergency response. I think everybody was running to man the pumps and firefight in relation to that. We had to pause for a minute and think what was the best use of the service that we had to support COVID. And really we felt that the project we had was actually standing up to the risks that COVID was bringing to us. So there was the immediate risk to the patient from the COVID, but there was the risk to the health service that the health service was going to buckle and not be able to function on it. That patients with non-COVID issues would start to deteriorate and be left out in the cold in relation to that.
Following on from Ronan, who provides the clinical governance for the project in our area. Just last year, we applied for Sláintecare funding to scale our service across the whole region, having only one community podiatrist in Wicklow and 3 in the acute care setting. We weren't able to provide a full foot protection service for the whole area. We had already run 2 quality improvement projects. One was led by Adele Kelleher, clinical specialist in St. Vincent's, who worked with vascular, endocrine, infectious diseases and orthopedics to create an acute diabetic foot pathway, streamlining their care, resulting in multiple positive outcomes. For example, instead of having an average stay of 21 days for diabetic foot ulcer, that was reduced to 7. The second quality improvement project we led out of St. Columkills was with my physiotherapy colleagues in Wicklow. We wanted to stop people ending up in hospital in the first place by treating them early, giving good preventative care in the community. For example, reducing waiting times for preventative devices from 9 months down to 6 weeks. When someone presents with an infected diabetic foot ulcer, it's like the fire has gone off in the building and you're fighting to put the fire out, but the damage has already been done. So for the first project in St. Vincent's, it was to treat that patient quickly, to pull them back from that. And the second project, which was run in the community, was to try to prevent the fire from ever happening in the first place. Both parts of the service are critical to stopping people from losing their legs. Sláintecare funding was critical to scaling our service through COVID by putting further staff in place. The first 2 podiatrists came into post in March when COVID hit, and a further 2 project members started in May. It allowed us to work quickly with senior management and clinicians across all our sectors to pivot our project and service to focus on what would become our key outcome measure, ED avoidance and avoidance of possible admissions, by accelerating the level of care outside of hospital and managing most of our care in the community in St. Columkills. We set up rapid access clinics only needing to refer to St. Vincent's when absolutely necessary. Sláintecare funding also allowed us to uplift the podiatry access in St. Vincent's to aid transfer of patients out to the community, to run a virtual clinic and to support the pathway to help patients out of our level 4 hospital faster and step down to community and level 2 care quicker. By working this way, we were able to offer 76 rapid access appointments for foot complications outside of St. Vincent's. 45 of these were seen in the community and 31 in our level 2 site. 63 of these patients presented with acute ulcerations, which otherwise may have ended up in ED, and some of which may have needed admission. Of the patients we saw, only 4 needed to be escalated for level 4 care, and we were able to offer 241 face-to-face appointments for continued care of these cases in the community, which helped ease pressure on the hospital. So far, 78% of these patients seen in the pathway have healed within 3 months and will continue to be managed to avoid future acute episodes. I'm going to hand you over now to Carmel Devine. She's the podiatry manager in CHO3 and lead of Project 343. Both the projects work closely together during COVID, sharing data, outcome measures, and developing resources. She's going to talk about the model we both worked on, her outcomes, and our learning from that.
Thank you, Anita. The COVID-19 pandemic is driving a significant change in the healthcare system and disrupting the best practices for diabetic limb preservation, leaving large numbers of patients without care. But podiatrists must mobilise and adopt the new paradigm of shifts away from hospital care to community-based care. This was from David Armstrong, one of our podiatry colleagues in the States in March 2020 at the start of the COVID pandemic. Whilst this pandemic and the necessary response created an unprecedented challenge to care provision, it was one we felt we had a duty of care to see the patients through and to keep them out of hospitals. Encouraged by international peers, our colleagues in UHL, Anita and colleagues in the East, we commenced working together in Community Health Areas 3 and 6 to provide a COVID-19 emergency integrated podiatry service. For us in Community Health Area 3, this rapid access was delivered in community clinics in Ennis and Limerick. We were conscious of maintaining capacity in the hospitals and keeping this most vulnerable group out of the hospital environment during COVID period. We were also cognizant of our Sláintecare project outcomes in terms of reducing referrals to outpatients and avoiding the emergency department. As you can see from this slide, we do have a national model of foot care for diabetes, and when a patient presents with a foot ulcer, they would normally be referred straight away within 24 hours and seen in the Model 4 hospital. However, during the COVID-19 period, we flexed and diverted this pathway to the community foot protection team and shifting the 24-48-hour rapid access from the hospital to the community foot protection team. In essence, the right care at the right time in the right place and speed trumping perfection. 24-hour rapid access was achieved in over 95% of our community referrals during this time. Keeping values and action principles to the fore, we contacted our existing cohort of patients with active foot disease, those in remission and at high risk, to keep them informed and let them know where to contact in the event of emergency or if concerned about a foot problem. The Sláintecare funding meant that we had an admin person in post to take those emergency calls and reassure the person calling of the now and the next. The community foot protection team, with podiatrists as its core, has stepped up by extending scope of practice, blurring roles to support each other, and rapidly acquiring new caring and remote consultation skills to offer the best possible care and support in difficult circumstances. This effort has demonstrated positive results, with 80% of ulcers seen during the 3-month COVID period healed. All have healed subsequently. A key component in achieving these healing times was having immediate access to offloading products. This was funded by Sláintecare project funding. Offloading is the most important of multiple interventions needed to heal a neuropathic plantar foot ulcer in a person with diabetes. Previously, patients may have had to wait weeks or months for these offloading products. The incidence of new ulcers after healing can be high also, with 40% having a new ulcer at the same site or a different site within 12 months. We observed several patients with more than one episode of ulceration during this 3-month period. Thus, the foot is not considered cured when an ulcer is healed, rather in remission, and in this respect it's clinically analogous to malignancy, as Ronan mentioned earlier. By readily identifying those with active foot complications and those in remission, we were able to flex quickly to deliver care to those most vulnerable. To date, this paradigm shift to the community has provided a learning opportunity to see how we could do things better and focus intensively on the care of those presenting or seeking emergency care. This has involved close working with other members of the foot protection team, the GP, the public health nurse, the CNU, the orthotist, CIT, and their colleagues in the Model 4 hospital. It has also involved a lot of patient advocacy, acting swiftly to support people to get the necessary care, some who choose to isolate out of fear. As a long-established service, trusting relationships between professionals in the foot protection team have been built, and with some considerable resilience, these have come to the fore in the pandemic. As we mentioned, we are stronger as a team when we work together. Self-referral is critical. There is some evidence to show that when patients self-refer, that they do better in the longer term. Communication and follow-up is critical, and we did note that during this period, in communication, while intense and at times maybe time-consuming, but it was essential and it helped us achieve the better outcomes. Timely, good decisions happen with the right voices at the table, and we always kept to the fore the Sláintecare principles of the right care, right time, right place. Representation at primary care management level is also vital, because we're looking after a very high risk cohort of people with a lot of responsibility around that risk. And so with that responsibility, you also need the authority to be able to make the decisions and the best decisions for those people. So now we're going to hear from Pat and Paul, who are clients of the service both in Wicklow and Limerick, to give the patient experience of the importance of the right care at the right time in the right place. I want to say thank you for listening, and thank you to all my colleagues on the team and all our colleagues in the Model 4.
I felt at the time that if I hadn't had here, I didn't know where to go or what to do, because the hospitals weren't getting calls from the hospital stating that I wasn't to go to any kind of outpatients. So it was unbelievable getting that call. It was a great relief, and because with the history that I have with amputations on my toes, it was very scary. And once I seen the people here, they really put my mind at ease, and they were on it from the word go, like, you know. Aideen and whoever else, first class. They automatically make you feel at ease. They tell you what's going to happen out in the car with your mask and everything else, and you know the routine when you come in. You're not waiting around. If you have an appointment at 9:30, you have it.
Right, my name is Paul Curley. I'm living in Cusheen, County Clare. I'm originally from Ennis, and I was diagnosed with diabetes maybe about 10 years ago. And I was very overweight, and now the only thing is I've also got chronic pancreatitis, which hasn't helped matters. So even though I'm on medication and insulin, I'm gone up to type 1 diabetes now. And I've been coming to the clinic here in Ennis, and also the one in Limerick, because of the diabetes. Unfortunately, spread to my feet, And as a result, I've had a couple of amputees, as in a couple of toes, etc. And I've also had an operation for charcoal foot. I had a sore in my bottom of the sole of my foot. And sure, like all men, I steeped it in salt water and went at it and picked it. And my eldest children said, "Oh, Dad, this is stinky." So I said, "I better go and get something else." So I went to the doctor. The doctor sent me straight over to the right clinic, and I met Karen Devine the first time. And ever since she's been looking after me and all her team. I was worried if I made a phone call, I'd be seen straight away, every time. Even if I rang them 1 in the morning at 9:30 and I was worried. The very fact that I was worried, and I tell others about it on the phone, I'm worried about this, they'll say, "Come in." And they've always seen, never, ever stopped me coming. Once you're in the system, I found there's no difference in care whatsoever. I found it a great experience all around. I suppose more, I won't say family oriented, more friendly, more innocent way from everyone. From when you open the door to the women on the desk and on passing the business manager. It's like they have, it's not their time in their hands, but they haven't forgotten that there's a person there behind number C125578, whatever it is. They haven't, and never, even in the hospital. I've been over there because of my job, this will take a toll. Now, and I'm going to Limerick tomorrow, I said, to surgeons have a look at it. And even there now, I'm into the acute, minor injury place. Everyone was absolutely lovely. But they hadn't, that's what I love about it. They hadn't forgotten, but yeah, that's the person with feelings and his normal life and his troubles and the same as everyone else's.
That's great. Thank you very much, Ronan, Anita, Carmel, Pat and Paul. There are some follow-up questions and I'll bring them to you in the panel slot presently. Our third project for you today is keeping people with severe epilepsy independent. St James's Hospital is the largest teaching hospital in Ireland, and its emergency department has over 50,000 attendances a year. Epilepsy is the most common neurological disease amongst young people and a common reason for admission through the emergency department. We'll hear from Dr. Colin Doherty, consultant neurologist, about how they are developing new pathways using remote and virtual care and reducing visits to emergency department. But first, Colin's going to tell us what their original Sláintecare funded project was about.
So thanks for that. Yeah. So yes. So this the video is going to deal with a little bit with the a survey we did of our telehealth program. But the initial impetus for the Sláintecare funding was dealing directly with the issue you brought up there about emergency room visits. So what we've shown over the last couple of years is that we've developed a sort of clinical pathway within the National Epilepsy Programme and shown a year-on-year decrease in admissions using the clinical pathway of patients coming in with seizures. And we've probably reduced the visits by about a third since about 2015. So that's a huge improvement. However, we saw that there were two groups that the pathway didn't really seem to affect. The first were homeless patients, and the second were patients with intellectual disability. Now, both of these groups have a high prevalence of epilepsy in them, much more than the normal population, and their experience of coming to the hospital is generally very poor. For instance, it's difficult to get homeless clients to engage with the normal outpatient services, and so they end up coming in regularly into the emergency room, almost like they're using it as if it's a primary care station. And secondly, the intellectual disability group, of course, have a terrible experience of sitting in waiting rooms waiting for care. By the time they get to come to see the specialist, usually they're terribly distraught, and so it's not very valuable. So we thought we would try and address these two groups for whom a normal pathway wasn't working. And so we've developed a very nice program now with the GPs from the Inclusion Health Safety Net group. And the idea is now that we use a sort of virtual encounter with the GP in order to give general advice that they can distribute to the patients who come in for their regular care. So it's a sort of an opportunistic move to help manage their epilepsy. And so I will be showing some data later in the year at this forum showing how we've managed to actually make significant inroads on the care of patients using the GP and ourselves as a co-specialist group. In the Intellectual Disability Centre, we've deployed our electronic record, which is a bespoke tool that we've developed over the last 15 years in epilepsy. It's a national record, and now it allows us to really provide virtual care. So these patients can be managed using telehealth, and they don't have to leave usually the residential centre where they're staying. So we have about 250 clients between Cheeverstown and Dr. Stewart's Hospital, and they all of those patients now are loaded onto the system. So, and our advanced nurse practitioners give advice to nurses and social care workers who look after these patients without having to bring them in.
Okay,
so you'll see issues in relation to the use of the electronic record now in this presentation.
Great stuff.
Good evening, everyone, and welcome to our presentation from the St. James's Hospital Epilepsy Service, keeping patients with epilepsy independent. For the next 10 minutes or so, I'm going to talk about our project, but particular emphasis will be put on the use of telehealth before, during, and after the pandemic. Sláintecare has as its motto, right care, right place, and right time. For years, we've been dealing with the crisis of overcrowding in Irish hospitals. We've had patients in corridors, medical staff stretched beyond capacity, dangerous and undignified. This situation appears to have literally no solution. Then COVID pandemic hit. And this happened. This was a Tuesday night in St. James's Hospital. I had brought a friend in who needed immediate care. We were amazed to see the emergency department almost completely empty, probably for the first time in 30 years. The outpatient clinics were also empty, with clinics cancelled and social distancing impossible. Clearly, there has to be some middle ground here. Many commentators have expressed concern about patients who had not presented to the hospital and were not getting followed up for both urgent and chronic diseases. Now, prior to the pandemic, epilepsy services around the country have, over the last decade, begun to harness the tremendous enabling value of technology. First, building an award-winning national electronic record. This moved us from these ridiculous charts to the use of video and telephone remote care. During the pandemic, all of us completed a rapid switch to telehealth. Even when 4 of our team got sick and the rest went into self-isolation, we were able to continue to deliver telehealth from our homes using our electronic record. But the question remained, was it valuable care? This project initially sought to understand the experience of clinicians and patients performing and receiving care in this new manner. Now to look at some data from the actual audit. This first graph is a data tree from the Power BI data analytics pack. The total rectangle represents all 1,392 patients seen in various clinic encounters across 2 large epilepsy centres, Beaumont Hospital and James's, between January and March 2020, before the COVID pandemic hit. As expected, the majority of cases were seen face-to-face in outpatient clinics. This is represented by the large green rectangle in the top left-hand corner. There were 511 telephone support encounters, usually unscheduled. And on the right, there are a range of other types of clinic that patients attend as part of the epilepsy service. In there are the beginnings of a small telehealth remote care clinic, which began in James's Hospital in January. Now look at the data tree from March to June 2020. What we can see is that the number of patients seen, 1,372, is only marginally reduced, so there was no backlog. The face-to-face outpatient clinic, the green square, has been reduced to 202 patients, and the vast majority of counters now, 708, are scheduled virtual clinics. The telephone encounter clinics remain the same, and the range of other smaller clinics are also similar, although the typical outreach clinics had also reduced due to the global pandemic. Now we will look at data from the clinician experience in the pre and post-COVID era. In the pre-COVID era, there were 45 responses. What we can see is, of those, 40 of the clinicians felt that the patient was appropriate for telehealth. In the post-COVID period, the figures unchanged, with 41 clinician responses deeming the patient to be appropriate for telehealth. Next, we look at the clinician experience pre and post-COVID in relation to whether or not the patient should continue their care virtually. Again, of the 45 responses in the pre-COVID era, the majority, 35, felt that the patient should continue their care virtually even after the pandemic was over. In the post-COVID era, the figure is slightly less at 31, but still a majority of clinicians felt they could continue their care virtually. Finally, in the clinician experience, the overall feeling from clinicians was that the care given virtually was either excellent or very good, with only a minority considering the care to be fair and no clinician feeling that their care was poor. This graph represents the responses from patients who attended the telehealth clinic in the 3 months prior to COVID. This clinic was relatively small and we only received 18 responses from 31 encounters. On the left, the pie charts represent patients' responses in relation to the type of transportation they normally use to get to the clinic. We can see that nearly half had to take time off work, and again, nearly half were using a private car to get to the clinic. In relation to the patient satisfaction, scale of 1 to 5, 5 being excellent and 4 being good, as we can see that the majority of patients that their interaction with the clinician was either excellent or very good, and that their overall experience with the service was either excellent or very good. In relation to the quality of the interaction, patients in the post-COVID era felt that the thoroughness and depth of the clinician involvement was either excellent or good in the majority of cases. Similarly, in relation to the question of respect, sensitivity and friendliness of the clinician, the vast majority of patients felt that their care was either excellent or good, with only a minority feeling that the care was fair and nobody feeling that it was poor. The overall experience of patients in relation to the telehealth delivery of care during the post-COVID era was again either excellent or very good in the vast majority of cases. And interestingly, the vast majority felt that they would like to continue their care virtually and that they would also recommend this care to other patients. The overall findings of this audit show that a sizable majority of patients are considered by their clinician to be appropriate for appointments by telehealth. Technical difficulties were not prevalent and patients were happy not to have to travel for care. The comfort, length and thoroughness of all appointments was mostly good or excellent. The overall experience by both clinicians and patients was either good or excellent for all encounters. The experience of telehealth was similar in the pre and post-COVID era, indicating that there was no special view of patients about their care during the post-COVID time. More than 90% of outpatient visits across Beaumont and James's were conducted via telehealth, thus far exceeding our stated goal in the original telehealth project, which was 60% reduction. However, a note of caution. The clinicians were more likely to want to return face-to-face visits, claiming that some patients are too complex and emotional issues were difficult to deal with. In conclusion, we believe that we have delivered on the promise of Sláintecare, this project, delivering what we think is the right care at the right place at the right time. And I would like to thank Cara Sinnott and Jack Banks and the rest of the Dublin Mid-Leinster Epilepsy team and the Future Neuro Research Centre who helped conduct this audit. Thank you very much.
And thank you, Colin, for that. On the panel this afternoon are the presenters you've just heard from, Professor Ken MacDonald, Dr. Colin Doherty, and the podiatry project people, Dr. Ronan Canavan, and I believe Anita Murray is also joining us. Let me come to you first, Colin, if I might, in regard to the epilepsy project that we've just heard about. Just listening to you there, I wanted to pick up on the point regarding the consultant's preference for face-to-face contact. how do you balance the clinician's desire for face-to-face with the overwhelming patient satisfaction with virtual services?
Hello?
Okay, we don't seem to have Colin at the moment.
I'm here.
Ah, Colin.
They are. Sorry, I thought you.
You're back.
Anyway.
Okay. So did you hear the question?
I got the question, yeah.
Okay,
so I
man.
think the first thing to say is that this service was predominantly delivered by nurse practitioners. There was a small number of consultants and some junior staff. But so in relation to the question of why they felt that the patients would be better off, more of them felt the patients would be better off coming face to face. I'm not really sure what's going on there. The patient's preference for this was overwhelming. They were probably building into this a whole load of criteria around, the fact that they didn't have to travel, they didn't have to take time off work, they were in a place of comfort. So the doctor just had one criteria, which was just the value of the face-to-face clinic. The patient had a lot more invested in this type of encounter than the doctor. So I think the simple answer is, despite some of the clinicians' concerns, I think a patient preference is overwhelmingly in favour of this type of encounter, and we intend to comply with that and continue to use it.
Great, thank you. Can I move on maybe to Ken? Ken, we listened with great interest to the heart failure virtual consultation service, and your project is, as you mentioned, building on the results of a similar initiative in Carlow-Kilkenny, reducing unnecessary referrals to both inpatient and outpatient hospital services, which for the patient obviously means appropriate care closer to home. What does the project need to be sustainable and mainstreamed nationally, in your view?
Yeah, great question. I think the concept is proven now. I think the challenge works back up from the people on the ground who've been developing it, the general practitioners, the specialists, the patients themselves. The challenge moves from them back up the ladder in the HSC and to fund this type of evolution and this development. And I think there's enthusiasm to do that. I think everyone involved sees the benefit. It's not that virtual consultation will take over outpatient delivery in any way. And in fact, our view of general cardiology, not just heart failure, from an assessment of the type of clinic that is needed, would suggest that virtual consultation could probably deal with about 40% of clinic requests. So I think there is a real need to invest, and that just comes down to money, resources, correct personnel, to expand this across the country, not just for heart failure, not just for cardiology, but as we develop it in other specialties, there will be nuanced differences between the way it's applied, between, for example, neurology or cardiology or other subspecialties. But bottom one word answer is finance.
Okay, money, investment.
Money, yeah.
Of course. And Ronan, moving on to the podiatry project there, can I ask you a similar question? What do you think your project needs to be sustainable and mainstreamed?
Yeah, thanks very much for the opportunity from HSC, Department of Health and IFEC to present our project here. I think what's interesting about the three projects is obviously the key issue is that how they're all community facing, and I think that is at the core of what Sláintecare is about. So I think we're all on the same page of where we're talking about. You could ask in terms of if we don't scale things, can we afford not to? I think bad care the way is not really what we can invest in the future. I think we want to invest in good care. So with regards to our particular project, I suppose it developed in terms of a small opportunity where we went and talked to our community, talked to managers in the community, went and met our MDT colleagues, physios and podiatrists and things like that. So that was our general approach to it. We had a framework, we had a National Diabetic Foot model of care, and we had that as our framework, and really we got that up and running. So when Sláintecare came, just, you know, we only really got started a year ago, and we're up and running, and we're delivering real outcomes. So I suppose essentially we've started baking a cake. We've had the recipe book, we've had the ingredients, and we put them in, and we produce what we think is a very good cake in relation to that. At the same time, this cookery book isn't just confined to us. People know where it is, what it looks like, because we have a model of care. We have a new model of care coming out for the diabetic foot, and that's probably going to be one of the first model of care in a COVID age. And essentially, while it was written pre-COVID, it fits in nicely with what can be delivered in the COVID age and after COVID. So essentially, we've got two people, different sites, bake two cakes, and essentially producing good care. I suppose what we need is buy-in from around the country, but I think the cohort, the key to diabetic foot care does focus around the podiatry care, and there isn't a good comparison there with COVID. We know that in COVID, we want the patient to break the chain of how it spread. In the pathway to diabetic foot, adverse outcomes, amputations, and ulcers, it's a pathway that's very clearly laid out, and the podiatrist is key to intervening at 2 or 3 points along that pathway. So what we need in good foot care is the patient starting off with self-care, and again that underlines any sort of structured care that we're going to deliver on top of that. The podiatry care that gets delivered can stop the patient, support them in the early phases, when the first ulcer presents, or when the patient is in an advanced stage with at-risk foot. So we have an energised group of within our podiatry colleagues, and I think within the community, when we start those conversations with it, we find our colleagues in the community are very much open to delivering on well-structured models, good recipes that are laid out there. And I think the question is, we want to go from two cakes to 10 cakes. That's what we need to roll out nationally. We need to double or to scale it up to that sort of level.
And maybe to give the last word to Anita, as one of the practitioners here. Anita, in your view, what's the greatest benefit to the service user of this new care pathway that you have developed? Is Anita with us?
I'm sorry, I didn't unmute. Thanks for having us on and for the platform. The greatest benefit, I think, to the patients and what they've come back and said to us is having that access to care, that rapid access to care in the community, close to home when they need it. Particularly during COVID, there was a lot of fear. They didn't want to be going into hospital. They didn't want to be exposed, and we were able to deliver that acute care closer to them. So I think that's been a real benefit, and also the ability to now do the virtual assessment, so to give blended care, so they don't always have to leave home. So often they will need to be treated and need a swift intervention, but some follow-up can be done in a couple of different ways. So I think that's probably been the biggest benefit we've seen. And I think in terms of our outcomes, we've been able, there was a huge study done over in the UK, and the consultant on the project, Dr. William Jeffco, came and consulted with us, and they shared some of their outcomes, and that's why we put the rapid access ED avoidance into the project, to try to make sure we could deliver on that, because we know the evidence is behind it that it works, and when you get them early, they're much less likely to end up in hospital.
Of course. Thank you, Anita. So many thanks to all of our guests here this afternoon, Ronan Fawcett, Siobhan Vreen, Ken MacDonald, Ronan Canavan, Anita Murray and Carmel Devine. Our next webinar is planned for you for Thursday, the 10th of September. Put that date in your diary, and do join us again to see how many frontline workers in partnership with local community services are making changes that really are improving the health and social care services for all of us as part of Sláintecare. Meanwhile, I want to thank the team here who helped produce this session: Rosaline Harlan, Muriel Farrell, Lindsay Dre, Ingrid Doyle, Jane Ann O'Connell, Erica Kinsella and Andrew Hannigan. If you're involved in a project which is promoting integrated care, please get in touch with us by email. You can watch the webinar back or recommend it to your colleagues, and it will be available on the Sláintecare website. And please do send us your feedback. The questions we didn't get a chance to answer in the webinar will be posted in the coming days for you. For me, Gráinne Healy, please stay safe, stay local and hold firm as Sláintecare continues to deliver on its promise of a health and care system that ensures we all have the right care in the right place at the right time. So to close out this afternoon, we're delighted to have Laura McGahey, Executive Director of Sláintecare, to say a few words. Thank you, Laura.
Hello everybody, thank you so much Gráinne, and thank you so much to all the participants on today's webinar. It's been a really interesting few weeks with fantastic presentations, and it's wonderful to showcase and see the innovations. And there's been a lot of follow-up from people asking for contacts of some of the presenters, in order that they can learn in a more detailed way off screen, off camera. I'm really delighted to be able to say that the innovation projects that had been paused as a result of COVID have now been reignited, and we are really looking forward to being able to feature those over the next series of webinars, which will be starting again in September. So thank you again to everybody, and best of luck with everything.